Thank you very much, and it's a pleasure to be here. Thank you to PK and congratulations to all of you for this wonderful growth of the meeting. My task is a humble one because I was asked to predict the future and where we're heading. And in this panel, there are opinion leaders about this, further a better position to talk about this than me, but I think PK wanted me to probably take you a high-volume operator who deals with this and try to come up with some sort of data and analysis. So we all know that the Taxel base is anti-restenotic cytotoxic, that is a fast absorption and long retention, but it's difficult to be delivered. It's easy to be delivered versus the Limus base, which is difficult to be delivered, but it's anti-restenotic and cytostatic, and also anti-inflammatory. In the coronary, it's been proven that Limus agents have effectively changed the landscape, and it's being used right now, but we all know that the SFA are not the coronaries. So it's all about kinetics, and the concentration of the drug is actually ultimately the determinant of effect. And when you're talking about balloon delivery, it could be either eluting or coated, and the mechanism is usually fast. This is a typical DCB curve, and kinetic-wise, in which the dose decreases significantly and abruptly versus a scaffold delivery system, which will be more consistent. So this talk is really about DCBs in the femoral segment, and these are the ones that we're going to be talking about today. So although they are all DCBs, they're all paclitaxel based, they're not the same in terms of pharmacokinetics. You can see in this slide there are actually differences between dosing, between excipient, but they all made it to market, and these are the ones that we have available, and Dr. Metzen mentioned the Ranger as a potential use for that particular case that he's doing. So Lutonix DCB, the density is, the dose is 2.0 micrograms, and the excipient is emulsifier, sorbitol, and polyaspirate, and you can see that the 12-month outcome was superior when compared to PTA alone at 12 months mark. Impact also actually was superior in effectiveness, different dose, different excipient, and you can see an 87% patency rate at 12 months in the DCB arm compared to 55% with a delta of 31. So clear superior. And when you have long-term data reported, like in the Admiral data, it's 75% almost versus 65 at 5 years mark. So again, long-term, I would consider long-term data for endovascular therapy. Celerex, also different dose, different excipient, also superior to PTA essentially with a delta of 12.8% at 12 months patency, but that at the 4-year mark did not actually hold truth, creating a similar profile in terms of effectiveness compared to PTA. Ranger actually also proven itself to be better compared to PTA with a different dose and a different excipient, and it went and compared itself in a non-inferiority design to another DCB, and I think this is a positive, and the data itself render Ranger non-inferior to Impact. So different dosing, different excipients validating actually good results. When we talk about Taxel, we all been through the Castanos paper, and the bottom line is there's been a myriad of energy, time, and money spent on proving that actually paclitaxel is safe to be used, to the point that the FDA provided us a letter saying there's no data that supports any mortality signaling, and we can go ahead and use it safely. So definitely, I think that's the subject that is behind us. So there are some advantages of Limus, and we're going to be hearing a lot about that, but these are primarily the difference between Limus and Taxel base. And currently in the United States, we don't have anything approved just yet. Sahil is going to be talking about the whole portfolio of Concept Medical, and this is looking forward to that talk. Recently published the Annals of Vascular Surgery, the Extosi 3-year data that in the femoral segment, just 20 patients only, proven a 12-month secondary primary patency and TLR that are acceptable compared to similar cohorts in the Taxel-based therapies, and a 2-year and 3-year mark also fairly similar profiles of effectiveness. So other technologies as well. The solution is Japanese-based, and again, they have a robust clinical program. Randomized trials are being performed, and the Limus flow study actually was completed and reported, and I have some data that hasn't been yet published, which is a paclitaxel comparison between the impact and the solution SLR, which is a Limus-based coated balloon. And the inclusion criteria was Rutherford 2 to 5. Target lesions were 3 centimeters distal to the bifurcation, and task A to task D. So range, a whole range of therapeutic, of lesion, anatomy lesion. So in this prospective parallel randomized controlled trial, the Limus base was shown to reduce inflammation, was shown to have improvement in the endothelial function by markers, but did not show any difference in primary patency or survival after 12 months, and TLR, CD-TLR. And this is another technology that is coming into play as well. So in order to put it together, my personal take is DCBs have largely replaced POBA in the femoral segment. Taxel-based DCBs, I think, are the benchmark, have a robust proven record of safety and acceptable performance in the femoral environment based on high-level evidence and real-world registries. Limus-based, with newer technologies, Limus is now reliably delivered from balloons, and small numbers, early data showed improved outcome when compared to PTA, and maybe similar performance with Taxel. So the exciting things that are coming down is 2 randomized controlled trials and presentation, and a head-to-head comparison between sirolimus-based and paclitaxel-based. If I were to bet, I think I will say that they're probably both gonna be similar in terms of the efficacy. Stay tuned. Thank you very much.